Is that your background or is that mine?
Hi, Cynthia. How are you?
I'm good. How are you?
I'm very well. Good to see you. Thank you for collaborating with us. We are also live on on YouTube, so I can hear you well, and I'll give you the permission.
I'm good. How are you?
Well, good to see you. I'll give you permission for being co-host. So you'll be able probably to share your screen right now.
All right, let me try it. Can you see it?
It's coming. Yes. Perfect. Perfect. So we are 5 minutes ahead. Tell us, how are you doing and how is your situation in Ohio? What do you think?
Well, I am.
Eu tô assistindo aqui.
So I am fully vaccinated, but I do most of my work from remotely. I did go into the Eye Institute today, but it's maybe once every couple of weeks when I need to meet with someone. I'm very fortunate that most of my work can be done remotely.
Here in Rio, we have, in Brazil, whole Brazil is doing the worst time of the pandemic.
You're having a surge?
Let me give a note to all my colleagues. Por favor, gente, vamos desligar o microfone de vocês. Daqui a pouquinho a gente vai começar. Se puder já deixar desligado, vai ajudar a gente. Obrigado. Boa noite a todos.
So it's the same problem with Zoom meetings everywhere that some people forget to mute.
Yeah, this is the same. I stayed at the office today because I know in my house my little girls, they are screaming at this time. So it's better to do it here. Otherwise, you'll be able to hear them singing, crying, everything.
I would enjoy the singing.
Yeah, the singing is nice, but sometimes they make too much noise.
How old are they now?
Giovanna is turning 7 and Rafaela is turning 6.
Wow.
They are a month and a half apart. Giovanna is in May and Rafaela is July.
My youngest is going to be 26 in June.
How is she doing?
She's doing well. She's doing well. She's decided she wants to go to medical school. So she's, this is just recently, she wants to be a radiologist. So we'll see how that works out.
Oh, beautiful, beautiful. Your husband and you should be very happy and proud.
This is your third final weight challenge you wrote yet. So tell me what you guys are preparing. So today we are going fully inspiration with the heart.
You're going to mute them, right?
Yeah. I hope I can. You.
Yeah.
Yeah. Yeah, Zoom meetings are all similar to this everywhere. Sometimes people make it unmute and they scream and it's sometimes funny.
It's probably, he says it's live streaming on YouTube. That was my husband that just snuck by, but he snuck by in front of me, so you didn't see him.
Congratulations for your daughter.
Well, she's not in medical school yet. She's just working towards it.
Yeah, well, she is clever. She's very clever. I can imagine my little girls going to medical school, willing to, deciding about it.
They are
It's-
way too young, way too young. I'm sure they want to be ballerinas, or, you know, they're at that age where, you know, which Stephanie was the same. She wanted to be a ballerina at age 6.
Yeah, they talk about everything, but Giovanna probably she says about being a doctor, but I don't know if, you know, if I want them to be, you know, medical profession. You need to love it, otherwise you won't be happy. And
Yeah, so I'll probably start on them when they get a little bit older about engineering. Because that's, you know, the STEM fields, that's, I think there's lots of opportunities, but they have to love math. And girls love math. Girls do better than boys in math until they're about in 4th grade, and then boys start to do better. So the time to target is 4th grade.
great. Cynthia, I think we are 7 sharp.
Hi, Renato. Can you hear me?
Gustavo, hey Gustavo.
Hey, how are you? I'm sorry, I was in the OR. Good evening, Cynthia. How are you?
I'm good. How are you?
It's so good to have you.
Well, this will be an interesting presentation.
Yeah, I'm actually driving right now because I was in the OR doing corneal transplant, and I was trying to drive and type my password to get in the room at the same time. I don't know if I'm showing my meeting or not. I'm not sure.
So we should right now. I will ask everybody to unmute the mic. Actually. So Cynthia, let's start.
All right.
Get the time and take advantage of everything. So, boa noite a todos. Muito feliz, muito especial para a gente, nosso grupo Corneal-RIO, poder contar com a Cynthia Roberts, que é uma amiga, acima de tudo, mas uma das pessoas mais competentes e de conhecimento notório em exames de biomecânica da córnea, exames de imagem, topografia, tomografia, ela é uma referência, várias publicações. A Cynthia Roberts é professora da Universidade de Ohio, em Columbus. Eu já visitei, uma cidade linda, fantástica, realmente um trabalho exemplar, inspirador, que ela faz já uma carreira de mais de 30 anos. So, Cynthia, I was telling them that I'm happy and honored to have you here, happy and grateful to have you in our keynote session with Corneal Biomechanics, what every ophthalmologist needs to know. And thank you very much for your participation. And we look all forward to your talk and then to the discussion afterwards. Thank you.
And thank you very much for the invitation. This has been actually, I communicated with Renato earlier today, and he told me that, you know, most of my talk is actually probably online, but just so you know, that's actually not true. I've added some new information, and we'll see how your response is to the new information. So let's see. I am a consultant to both Zemer and Oculus. So there's somebody that's not muted. The published clinical applications for biomechanics, this is just a subset. Certainly identifying at-risk corneas prior to refractive surgery is very important, but I am not going to deal with that today because I think the world's expert is Renato Ambrosio, so I will leave that to a future talk of his. However, I do want to discuss the biomechanics of LASIK versus SMILE, and I want to give you some very important clinical advice. So what I tried to do is focus on real clinical applications where there's something that you can take with you to your practices. IOP measurement error is critically important, not only in glaucoma, but in refractive surgery, especially as patients who have had refractive surgery age into the range where they might develop glaucoma. Also, the biomechanics of keratoconus, and this is important to understand so that you can appreciate how customization of cross-linking will actually produce a better result than a uniform cross-linking treatment. And also, there's a very recent article that was published that you can predict glaucomatous progression based upon corneal biomechanical measurements. And then the final thing that I want to talk about is actually my own work. And this will come out in Journal of Glaucoma very soon. And that is predicting the IOP response to prostaglandin treatment so that you might be able to determine upfront using a biomechanical analysis, which patients would be more likely to respond to prostaglandins and which ones would be more likely not to respond. So how are biomechanics measured? Well, biomechanics is a response to an applied force. So you have to perturb the tissue in some way. You have to do something to actually generate a response. And that can be something destructive, like cutting a strip of a cornea and stretching it, or for clinical applications, it must be non-destructive. We quantify the biomechanical response with properties classically, but in clinical devices, we haven't gotten quite that far yet, but we can correlate them to biomechanical properties. Examples are elasticity, viscosity, and viscoelasticity. And it's important to understand the differences between this because it'll help you understand the differences in the parameters produced by the two different commercial devices. So elasticity, you can think of that like a spring. The response of the spring is dependent only on the force you apply. It doesn't matter how fast or how long you apply the force. There's no time dependent component. It's only what the force is. And if you remove the force, it goes back to its pre-force application state. Viscosity is the resistance of material to flow or permanent deformation. There's a time-dependent component, and what I have illustrated here is honey coming off a little honey wand because the force here is gravity, and the time you apply that force determines the response. And then viscoelasticity is the presence of both viscosity and elasticity in the same material, and that has a time-dependent component. And the best example I could come up with that is a memory foam mattress. Now, if you hear elasticity or elastic modulus, what is being described is the response of the material. This shows on the x-axis strain, and what strain is just stretch. How far does the material stretch as a function of the load, which is on the x-axis or the stress? So that's what's called a stress-strain diagram. And this shows a linear response, but if a material has a higher elastic modulus, that's shown in blue, it has a higher slope. If it has a lower elastic modulus, can you hear me now? I didn't know I was muted. The higher elastic modulus will stretch less than the lower elastic modulus. Now, nonlinear elasticity means that you can't just look at the slope of the whole curve because the slope is changing. And this is the behavior that's exhibited by a cornea. As the stress goes up, stress is a function of IOP. So as IOP goes up, the response will change. The elastic modulus will become greater. So that you have to look at the whole curve, and you can characterize this either with a tangent modulus at that point, or the secant modulus just connects it to the origin down here. But this is a function of load, and you all certainly surgeons know the higher the IOP, the stiffer is the eye. Now the cornea is viscoelastic, and what that means is that loading and unloading have different paths. It's nonlinear elastic or hyperelastic, which we just described. So as IOP increases, the cornea exhibits stiffer behavior, and one modulus is not sufficient to fully characterize the cornea. Now, I talked about these properties, but I didn't mention hysteresis. And if you look at biomechanics in the literature, there are over about 800 papers that are on corneal hysteresis. So why didn't I describe that as a classical property? So hysteresis is the difference in response during loading and unloading. And there's an example of that down here, where here's where you're stretching it and here's where it's relaxing. So the path is different. And what that means is there's a different response in the stress strain curve. It only occurs in a viscoelastic material, and it does not correlate to stiffness. When you hear corneal hysteresis, and I'll explain this more in a little bit, that's a difference in the applanation pressures. That's described that way by the manufacturer. It could be a difference in other parameters. For example, you could even look at the area between these two pathways, or other kinds of differences. Now, I want to talk about refractive surgery for a little while before I talk about IOP measurement error, and we'll talk about LASIK versus SMILE here. The biomechanical response in refractive surgery can be in two different categories. One is stable modification of every treatment outcome. This is what I'm going to talk about. Unstable decompensation can be either an at-risk cornea preoperatively or too much tissue altered by surgery. And this I'm not going to deal with today. So if you think of the cornea as a series of lamellae that are stretched because they're tied at the limbus and they're loaded by intraocular pressure, so they're stretched. And there's cross-linking between these different layers, so there's connections. So if you sever any of these lamellae here, you will leave peripheral lamellar segments that are no longer in tension, and in fact will never be in tension again. So that change in the structure generates a biomechanical response, and it causes thickening in the periphery, and the thickening in the periphery, because of the cross-linking between the layers, causes central flattening. So you can think of this as rubber bands stacked one on top of the other with sponges in between. If you pull on the rubber bands, it squeezes the water out of the sponges. And we all know the cornea is in a state of relative dehydration. But if you cut any one of them, it no longer has the tension to keep the water out of the sponges. And that's this redistribution of water is what's causing the thickening in the periphery outside of the area that's been cut. So this is 2,380 patients that were treated in Hong Kong in the 90s. And I still use this because this is when they were using a spherical ablation profile, which produced an exaggerated biomechanical response. But it shows that the entire cornea responds. If you change the structure of it, it doesn't change its shape only where the laser is applied. The entire cornea changes its shape. So this is the average difference map of all 2,380 subjects, where the optical zone is captured between this white circle and this white circle. So everything from here to here is transition zone, and everything inside this central white circle is optical zone. And you can see that the entire cornea has been changed in terms of its shape. All of these were myopic treatments. So centrally, where there's a negative number, curvature has decreased. And in this transition zone, where there's a positive number, curvature has increased. Now, if you divide this by level of correction, and we divide it up into the 25 patients who had less than 2 diopter corrections, you can see on this that there is a modest central steepening and modest modest central flattening, and modest peripheral steepening. But if we step through this by level of correction, 2 to 4, 4 to 6, 6 to 8, 8 to 10, greater than 10, you can see that this flattened area, the decrease in curvature, is getting smaller with increasing treatment. And this area out here in the transition zone is having a greater increase in curvature. That's biomechanical. So the curvature in the outer region, which corresponds to the transition zone, increases with increasing level of correction. Pachymetry, let me go back and show you that. This is the pachymetry difference map. Again, this is transition zone where tissue has been removed, and you can see that there is an increase in thickness out in this area. So there's zones of increased pachymetry in this outer zone despite ablation. The increased curvature leads to increased spherical aberration, and it's consistent with that biomechanical model that I showed you. The device used that I showed you is an orb scan, but Dan Reinstein, near the same time this was described, used high frequency ultrasound and showed that there's an increase in thickness outside of the central area where tissue had been removed. So what does this do? This central flattening actually enhances a myopic procedure because you get additional biomechanical flattening. It reduces the effect of a hyperopic procedure. It causes flattening in the supposed non-refractive PTK. If you remove tissue, it's not a non-refractive procedure. And then it induces these paracentral and peripheral shape changes that result in aberrations. Now, what does biomechanical properties have to do with results? And that's hard to evaluate clinically because it's difficult to evaluate what is the modulus elasticity. So Abhijit Sinha Roy and BJ Dubes in 2009 built a biomechanical model so that you could actually have a fixed amount of tissue removed in a myopic procedure and see what happens if you change the properties of that cornea. If you have low stiffness, there's a difference in response between the center and the periphery and causes an undercorrection. If you have high stiffness, it's the opposite, and you have an overcorrection. This is the source of the age nomogram. You need to do additional tissue removal with young people and less tissue removal with old people. That is why there is an age nomogram. Does the flap change the structure? And, you know, at this point in time, everybody knows the answer to that. But when we started looking at this, everyone thought that it did not change the structure. So we know it can be lifted years later. And the magnitude of the flap response really depends on the flap maker. But what they all have in common, and is shown by all of these studies on this slide, is no matter what flap maker you use, even a femtosecond laser, Dan Tran here, they all produced a hyperopic shift. The higher order aberrations were distinct depending on the microkeratome or the femtosecond laser used, but they all had in common a hyperopic shift, which means they all had this central flattening. Now, John Marshall actually, his group published a study where they wanted to look at the difference between a 90 micron flap and a 160 micron flap. Was there a difference in corneal response? So they did this in a corneal culture model. But remember, if you're looking at a biomechanical response, it has to be, you have to perturb the tissue in some way. So what they did is they raised the pressure from 15 to 15.5 millimeters of mercury. And they looked at the difference in strain. And they found with a 90 micron flap, there was less difference in strain than with 160 micron flap. And by the way, that's not, the flap carries no tension. This difference is due to the difference in the residual stromal bed. The response is driven by the bed, not the flap. It just sits there. It can't carry any tension. But if you do a side cut only, you can see that the amount of strain matches that for the entire LASIK flap. If you do the delamination only, it's very small. So this is important evidence that shows you that where you sever the lamellae, where you cut the lamellae, that's what generates the response. Dan Dawson actually did some work that showed that the strongest region of the cornea is the anterior region, and then it decreases as you move toward the periphery. Because of that, SMILE was developed. And SMILE was developed to replace a flap procedure. So if you use a femtosecond laser and you do 2 passes and you create a lenticule and you do a very small side cut. So this is the only thing here that's going to be severing lamellae from the surface. And then you remove this lenticule. Now, the thing to remember is there's lamellae going through this center here too. So you still have severed lamellae in the periphery. The width of the thickest part of the lenticule, those lamellae have been severed. So working with Abhijit Sinha Roy and BJ Dupes, we built a model to compare LASIK to SMILE as a function of the tissue removed and how many lamellae were cut. So obviously in SMILE, there were fewer lamellae cut than in LASIK, just due to the difference between the cap in SMILE and the flap in LASIK. And what we found, which again, this was very early on. If you look at the post-op geometry, this is not the pre-op geometry. So this uses post-op geometry, but there's no cuts and no tissue removed. It's as if it's an intact cornea of the same geometry as the LASIK and the SMILE eyes. So people misinterpreted this as pre-op because there is no stronger cornea than the pre-op cornea. So this is post-op geometry. And what you can see is the LASIK eye, these are the flap cap region in the first row, and this is the residual stromal bed in the second row. And what you can see is because of the maintenance of the integrity of the anterior layers, that the cap region carries the same amount of stress as in the post-op geometry non-operated model. But LASIK, the flap cannot carry that stress anymore, so it drives it into the bed. So this is all driven into the bed here. So you can see in the bed in the SMILE eye, it's very similar to the intact eye. And in the LASIK eye, there's an increase in the stress in the bed. So there's less severing of the anterior lamellae in SMILE, greater maintenance of integrity, and the stress distribution is closer to the unoperated state with post-op geometry in SMILE than in LASIK. Now, what didn't we take into account? Again, this is very early days. If you look at this lenticule, you can see that the arc length of the anterior surface of the bed is shorter than the arc length of the posterior surface of the cap. There is a mismatch. You can't get around that because to get a refractive effect, you have to remove this tissue. So what that means is that cap area, even though the lamellae are intact, it has less tension than pre-op. It has to settle in. And that means if IOP goes up, it's still going to be carried by the bed. We did another finite element study, but in this time, instead of being pure theory, we actually used 10 eyes of 5 patients that were treated by Jesper Hjortal in Denmark. And he did SMILE in one eye and flex in the fellow eye. Flex uses a femtosecond laser to create the lenticule, but then also cuts a flap. So we didn't want to compare excimer ablation to a lenticule. So this actually is very similar in both eyes of this single individual, except one eye has a small side cut and one eye has a flap created by the femtosecond laser. They both have lenticules. And then patient-specific inverse finite element analysis was done. And what that means is you build the model with pre-op tomography. You need to have anterior posterior surface. And your post-op tomography, which we know is the target. So then you iterate this model by changing the properties until you hit this post-op target. And what we found is that the flap procedure had a greater mean reduction in stromal collagen fiber stiffness than the contralateral region in cap, in SMILE, and there were lower stresses and deformations within the residual stromal bed in SMILE eyes. So this is what we predicted with the theoretical model. So SMILE offers very distinct biomechanical advantages over LASIK. However, there's many howevers here. The strongest cornea is the pre-op cornea. You have to remove the tissue to create a refractive effect, but you're never going to recover pre-op strength, even if you cross-link. You will weaken less, you will not recover pre-op strength. So the primary effect of refractive surgery, the primary biomechanical effect, is the amount of tissue removed. No matter how you do it, you have to remove the tissue to generate the refractive effect, and that is the biggest biomechanical biomechanical effect. A secondary effect is the location of the tissue removal, whether at the surface, under a flap, or under a cap. That's a secondary effect. Now, at-risk corneas by pre-op screening may indicate that there's an underlying biomechanical abnormality. If it exists, this biomechanical abnormality will overcome any biomechanical advantages with SMILE. The biomechanical advantages that I described are only in a normal eye. So you should not use SMILE as a backup for LASIK. Now, if you look again, this is a surface here, and then you move down toward the posterior of the cornea, and you can see the greatest strength is in the anterior region. Now, if you have a biomechanical abnormality, it may likely be in this anterior region. So if you're doing a surface ablation, you may ablate it away. So a surface treatment, you can think of as an appropriate alternative if you don't want to do LASIK. But if you don't want to do LASIK, don't do SMILE. You only get that biomechanical advantage in a normal eye. Don't use it as a backup. So any incision, ablative femtosecond disruption that cuts tension-bearing lamellae will generate a biomechanical response and change your surface shape, which affects the visual outcomes. All right, now I want to talk about measurement error with IOP measurement error, and this is extremely important for both refractive surgery and for glaucoma. So we all are very familiar with Goldman tonometry, applanation tonometry, where the force applied is proportional to the intraocular pressure. The assumptions, there's multiple assumptions in it, but the biggest assumption is that all corneas are the same. And we know that's not true relative to central corneal thickness, because as far back as 1975, people were generating correction factors based on corneal thickness to reconstruct IOP. And you look at all of these, and of course, as a clinician, you're going to think, which one should I choose? But as an engineer, my question is, why are they different? Why isn't it consistent if central corneal thickness is actually the primary source of measurement error? They should be similar. Well, why has the influence of corneal thickness been recognized? Because you can measure it. If you can measure it, you can take it into account. But I want to share with you, so now these are just two of the algorithms for refractive surgery, but again, why are they different? So something must be affecting measurement error other than central corneal thickness. So, and the accuracy of this is important. So we built a model of applanation tonometry, and of course, assumptions are always made with regard to thickness, but we wanted to look at properties as well. So with this model, and this was published in 2005 in JCRS, if you look at this green line in the middle, that is a true pressure of 15 millimeters of mercury. Here is our theoretical prediction on the y-axis of the IOP reading and corneal thickness across the x-axis. Now, this is from 300 to 800 microns. So if we bound that by what you would actually run into, and we see the impact of that on this true pressure of 15 millimeters, the error here is maybe 2.5 millimeters of mercury. It's not enough. It's not enough to give you heartburn. But if you look at properties, and again, here, this green line is 15 millimeters of mercury. And we look at, first of all, this range of modulus is a fraction of what's been reported in the literature. So we're just going to put this in and look at it for illustration. And you can see that the potential error is huge. This is 17 millimeters of mercury. So what this tells us is that potentially, right now, corneal biomechanical properties have a larger influence on measurement error than central corneal thickness. Now, I showed you what happens as each of these are independent factors. But as we all know, curvature, thickness, and properties vary at the same time. So let's look at two different things. So here we've still got corneal thickness on the x-axis, theoretical prediction on the y-axis, but we're looking at two different moduli of elasticity. So this top one is the stiff cornea, and this bottom one is the more compliant or softer cornea. And you can see that there's a significant difference in the slope. So what this tells us is the stiffer the eye, the greater the influence of central corneal thickness on measurement error. The less stiff the eye, the more compliant the eye, the softer the eye, central corneal thickness may have no impact on measurement error at all. So the modulus actually determines the relationship between central corneal thickness and IOP measurement error. So, and this is actually what I just told you. Now, can you correct IOP measurement with a simple linear conversion based on thickness? You know, people do it all the time. It's not accurate. In fact, you could be correcting the wrong way. What about a thick, soft cornea or a thin, stiff cornea? And these thin, stiff corneas, I'm going to show you in a recent paper, are important for predicting glaucomatous progression. So you have to be careful in terms of IOP measurement error. Now, what we know after refractive surgery, what everybody assumes, is that IOP decreases. It's assumed to be a function of change in curvature and thickness. And I'm gonna, say that there's something missing in that. This is actually my absolute favorite plot that's in the literature. Is published in Ophthalmology in 2005. And it's a study of 8,113 subjects. And they reported the mean difference in IOP. So this is IOP change, measured change here. And this is the refractive change here. So everybody with a 5 diopter correction had the same difference in central corneal thickness. Everybody with the 10 diopter correction had the same change in thickness. But they came to the conclusion it's about a 2 millimeter reduction in measured IOP. The R-square, which tells you how much of this change is predicted by this, is 0.009, which tells you that this explains less than 1% of the variability. And in fact, if you look at a 5 diopter treatment, you could pick any value from +10 to -12. So you could really make up a reasonable value of IOP and write it down and do better than any kind of applanation tonometry after refractive surgery. Now, look where 0 is. Here's 0 right here. So there are literally thousands of patients who had an increase in measured pressure rather than a decrease. Well, what could cause that? Do I think these eyes are stiffer? No, they're not stiffer. They've all had tissue removed. None of them are stiffer. So what explains this? And what I propose is that the problem is the pachymetry profile. So if you look at the assumptions made by Goldman, there's an assumption, there's assumption that the cornea is infinitesimally thin, but certainly over the years, we found, the more uniform thickness the cornea is, the better applanation tonometry will do. Well, what have we done after refractive surgery? We've taken the thinnest part of the cornea and thinned it more. So we've created this pachymetry profile that completely invalidates all of the assumptions of applanation tonometry. It is an invalid device after refractive surgery. And this actually, Hanato actually sent me these. So here's our pachymetry profile pre-op. And here's the same eyes, the pachymetry profile post-op. It's dramatically changed. And that makes Goldman tonometry completely invalid. This is another case that was published, and this shows something different. This is not just that applanation tonometry will get the wrong value. There's a different reason behind this one. So this patient came in and had 12 millimeters of mercury by Goldman on February 15th, 2012. That same day, this is the right eye with the Corvis, where Goldman said 12, Corvis said 53.5 millimeters. This patient had pressure-induced stromal keratopathy. But why is that? That's because, again, that flap is sitting there. It's not in tension. And as IOP goes up, the bed carries that stress. It's not transmitted to the flap. And in fact, the Goldman probe can get lost in that low tension or no tension flap and fool it. You can fool it. So even if you could potentially get an accurate value with the applanation tonometry, which you can't, but even if you could, if you get this increase in IOP, it's an additional source of error. Well, you can't fool a device which inverts the cornea. You can't fool it. You can fool it if it's just trying to flatten the surface, which is staying completely inside of a flap, but you can't fool it if you're inverting the cornea like this and making it concave. And that's why I would recommend that you don't use, that's the second reason why I recommend you don't use applanation tonometry after refractive surgery. I would use a different technology. So with IOP measurement error, central corneal thickness is what you can see, but you know, underneath, you can't see underneath the water is everything else, which impacts it far more than the central corneal thickness. Okay, so the next topic is keratoconus. Now, this was created by Keith Meek using X-ray scattering, and this is the preferred orientation of the collagen lamellae, because as we know, there's 300 to 500 layers, varying orientations. But if we look at the preferred orientation in the center is vertical and horizontal, and then as you get toward the limbus, it starts becoming circumferential. That explains the data of Ahmed El-Sheikh, where he looked at vertical and horizontal specimens with very similar stiffness, and then diagonal specimens where, again, the stiffness is much lower. It's down here. So if you have a particular stress, you're going to get this much stretch on the vertical and horizontal and way more on the diagonal. So it really matches the structure. What drives the stiffness is the structure. Now, what happens in keratoconus? Because for a long time, everyone thought of keratoconus as an all-over weakening. Well, in keratoconus, it's not an all-over weakening. The pathology is focal. And in fact, this disruption in the lamellar architecture is very focal. And you can see around it, it's relatively normal. Now, if you look at the curvature, you know, so here's your normal cornea. Here's one that has, this is quite, as you know, I don't need to tell all of you how advanced this one is, but you have this asymmetry in curvature and asymmetry in properties and asymmetry in almost anything else you can come up with keratoconus. But I want to propose something I actually first put out in 2007 before any of the measurements were done to actually verify this, that curvature, thickness, and elevation changes are secondary symptoms of preclinical keratoconus. The primary alteration is focally biomechanical due to this focal disruption in the lamellar architecture. And this diagram is altered based upon what we published here in 2014, because in discussions with Hanato, he convinced me that that it should go in this direction, that the focal thinning is going to happen prior to the focal increase in curvature. And he's correct, because and I'll show you with some additional slides why this is correct. So this redistributing of the stress is because of this focal reduction modulus elasticity. So in that one region, it's going to stretch more than the rest of the cornea with the same IOP. So you have this one region that's going to stretch more, and that makes it thinner. And as it becomes thinner, that redistributes the stress. And what the cornea does to compensate is increase curvature, which redistributes the stress. So you have this biomechanical cycle of decompensation that once you start it, it keeps going unless something interrupts it, like cross-linking to stiffen it, you know, that kind of thing would interrupt it. Now, if you look at the old literature on keratoconic corneas, they use strips and they stretch them. So if there was an asymmetric area of weakening, the whole strip's going to be weak. So they made no effort to look for asymmetry of properties, which is why I think people thought that there was a global weakness. But with the Bruin microscopy, which is a non-contact assessment of light interacting with natural acoustic phonons. There's no acoustic wave that's shined into the cornea. It's only laser. And what he found both in this experiment and in the one I'll show on the next slide. He took ex vivo buttons. The normal donors were from DSEC, and the keratoconic corneas were from DALK, and measured them. And on all the normal ones, you can see that it shows the same thing that we've talked about, that the greatest strength and a Brion shift is associated with greater strength, is in the anterior region, and then it decreases as you move toward the posterior region. In the keratoconus, you can see in this middle graph that not only is there a reduction at the anterior surface, but really this whole structure is disrupted. But on that same keratoconic cornea, that same graft, if you move to the area of pathology, so if you move to the area not in the, I'm sorry, the keratoconus cone region is the center one, but in the same corneal graft, if you move to an area away from the pathology, you cannot distinguish this from normal cornea. So this shows you that there's asymmetric properties that go along with the asymmetric curvature, that go along with the asymmetric thickness, and all of the other asymmetries in keratoconus. And he also did this in living eyes. So you have a normal subject on the left, a keratoconic subject on the right, and you can see that there is asymmetry in this keratoconic subject, which shows exactly where the pathology is, exactly where that disruption in the lamellar architecture that Keith Meek showed is. So there's a focal weakness in biomechanics, focal weakness in keratoconus. And the best way to detect this, which we haven't done yet, but the best way to detect it would be asymmetry of properties, because you're going to have a distribution of properties in keratoconus like everything else with a focal weakness. So the best way to detect it would be asymmetry of the properties, and we haven't quite gotten to the point where we can do that yet. Now, IOP has a confounding influence on biomechanical assessment. So what that means is that you have to take into account IOP, because if you had a keratoconic subject with a higher IOP, they may exhibit stiffer behavior than a normal cornea with lower IOP. So this IOP actually confounds your biomechanical assessment. Now, stress distribution. I don't expect you to remember this, but I want to show you that we calculated the stress, which is a function of the pressure, curvature, and thickness. Radius of curvature in the numerator, thickness in the denominator. So higher stress, this everybody knows, the thinner it is, the smaller t in the denominator, the larger the stress. This everybody knows. But what not a lot of people realize is that higher stress is in the flatter region because you have a greater R in the numerator. So thinner and flatter is the highest stress. So if you look at keratoconus, what dominates the stress distribution? Is it thickness, as everybody thinks that you have a stress concentration where it's thinnest, or is it curvature? So do areas of thinner pachymetry and greater curvature have the peak stress, as is often assumed? And the answer is no, they don't. So if you look at curvature here on this lower right map, you can see that there's this focal increase in curvature. And if you look at the stress distribution in this upper right map, you can see that the lowest stress, the blue area, is associated with the greatest curvature. The lowest stress is associated with the greatest curvature here. So the stress distribution in keratoconus is driven by curvature, not thickness. And in fact, due to all these asymmetries that we have looked at, if you wanted to customize your cross-linking procedure, you should make do a greater treatment in the area of pathology than the surrounding areas. I don't think you should only do that area, because you can't have an area that's been treated right next to an area that's been not treated. You need to have a gradual change, but you should do more treatment in the area of pathology than the area of around it, just because of this asymmetry. And also it tells you that this is why this curvature, this is why rings work. Because if you change the curvature, you immediately change the stress distribution, and you try and reverse that cycle that I showed you. So curvature drives the maximum stress distribution, not thickness, as is often assumed. So again, how are we going to evaluate all these things that I just described to you clinically? And of course, there are two commercial devices. you're all aware, and they are dependent on response to an air puff. And that's where the similarities end. They use an air puff to deform the cornea, but the strategies they use for the air puff are completely different. And as we learned, biomechanics is response to an applied load. If that load is different, the response will be different. So these two devices are really complementary. They're not competitive because you get different information from each device. In the ocular response analyzer, the air puff is customized to each patient. So a lower IOP would receive a lower pressure, lower air pressure, and a higher IOP would receive a higher air pressure. And there's an indirect analysis of the signal, and I'll show you that in a minute. With the Corvis, the air puff is constant, and then there's a direct analysis of the images. But the parameters you get from the Corvis are different than the parameters that you get from the ocular response analyzer, and they provide different information about the cornea. So first, the ocular response analyzer. It produces something called corneal hysteresis, and that's what I'm going to talk about. And as we know that hysteresis decreases after refractive surgery, and we also know it's lower in keratoconus. And I think these were the first groups that were measured when the device was developed, and that's why people may develop the misconception that low hysteresis meant you had a weaker cornea, because it's just not true. If you take anything else from here, corneal hysteresis does not mean you have a low corneal hysteresis does not mean you have a weaker cornea. And so what we did is we took an ocular response analyzer and we put a camera temporally and a camera inferiorly, and then we added our images to Damien Gantinel's schematic of how this works. And I'm just going to step through this quickly because I think probably most people are familiar with it. But what I want you to remember is, this is the applanation signal. This will be the red signal down below. You can see I hope you guys can see my cursor because I'm pointing to things with the cursor. So you can see this applanation signal is a function of how many photons hit that detector. If you remember that, you can interpret the signal. So as the cornea applanates, it aligns with this detector and you get a spike. So the height of that spike is a function of the number of photons that align with this detector. And then it goes through applanation, recovers a second time. Again, you have all these aligning with the detector, and then it's over. So the air pressure at the first applanation point is pressure 1. At the second one, it's pressure 2, and hysteresis is described as the difference in applanation pressures. The first one is always higher than the second. If you have a measurement where that's not true, it's an invalid measurement. So the device produces 4 parameters: Goldman correlated IOP, corneal compensated IOP, corneal hysteresis, and corneal resistance factor. Now, what you will see in the literature is that hysteresis is the viscoelastic response and CRF is the elastic response. That is not true. They are all a function of P1 and P2. P1 is the loading, P2 is the unloading. If P2 is part of the equation, then there's a viscoelastic component. So there's nothing in here that's going to give you purely elastic response. You can think of CRF as weighted by elasticity because it has more of P1 than P2, but it still has P2 involved in it. And with 4 parameters and 2 independently measured, P1 and P2, you can only have really 2 independent ones. So we tend to choose hysteresis and IOPCC. I think I've told you this. What hysteresis indicates is the cornea's ability to dissipate energy. And this shows you, Dave Luce gave me this image, and this shows you that the cornea flattens down here. There's the first applanation pressure, becomes concave, and then as it returns, it follows a different path. There's the second applanation pressure, and there's returning to the original shape. So this corresponds to the classic hysteresis pattern. Can you use it for screening? Well, even though keratoconus has a lower hysteresis than normal, there's too much overlap to use it for screening, so it's not good for that. But there is important information from the signal, and there's going to be, I'm going to show you multiple times why this is important. So you can look at the height of this peak. The higher it is, the stiffer is the cornea. And you can look at the width of this, that's velocity. The thinner that is, the faster the cornea is moving. So there's all kinds of other things that you can look at with this signal. As an example, this was first published in 2008, where we looked at, these are bilateral eyes from the same patient, sent to me by Joseph Collin, who was the president of the French Ophthalmological Society. And this patient was sent to him, and the eye that had post-LASIK ectasia had blunted peaks, and the post-op eye without the stable post-op eye had higher peaks in it. So clearly hysteresis wasn't different between them, but the characteristics of the signal were distinct. This is a patient that has had cross-linking. So the red lines, the applanation signal and the pressure signal, are prior to cross-linking. The blue are a year after. There's no difference in hysteresis, but look at the difference in the signal morphology. The peaks are much higher. This is clearly a stiffer cornea. That is a function of number of photons hitting the detector. So the analysis provides important additional information regarding biomechanics. Now, a newer device is the Corvis ST. So this device uses a high-speed camera with Scheimpflug geometry and captures about 140 images over 30 millisecond window. The air puff itself is probably more like 21 or 22 milliseconds. And what is Scheimpflug imaging? And I wanted, because a lot of people don't understand this, but I wanted to show you the difference. So if you look at this, the blue line is the object plane. The red line is the lens plane, and the gray line is where it's imaged. So you can see here the part of this railroad that's in focus on the left is across it, and it's out of focus in front and behind the focal plane. But if you turn that object plane along the railroad and you tilt the lens plane and the image plane so they all intersect in a line, it gives you tremendous depth of focus. And that's Scheimpflug geometry. You can use it for a lot of different things, but it really lends itself very well to looking at the eye, because you can illuminate it and the slit is the object. And then in that camera, both the lens and the imaging plane are tilted relative to that object plane. So you get this tremendous depth of focus. And you get the same with the ORA. You have first applanation and on the way in, second applanation on the way out. And in the middle, you have highest concavity. And the shape of this deformation tells us something about stiffness. But the strongest predictor of deformation amplitude is IOP. If you look at two groups, one of them has a higher deformation amplitude than the other, then the one with the higher deformation amplitude has lower IOP. That's your first conclusion. So there are certain parameters that are relatively independent of IOP. Those are the shape parameters. Certain parameters that really are highly dependent on IOP, and you have to take into account IOP if you're trying to compare these. This is what happens during deformation. The blue line is apex displacement. The green line is whole eye motion. So what happens is, and if you subtract the two, you get the red line, which is cornea motion only. So when the cornea reaches the limit of its deformation, that's when the whole eye starts moving backwards. Then as the air pressure in gray reaches its peak and starts coming down, the cornea starts to recover, but the whole eye is still moving backwards. After the cornea recovers, then the whole eye moves forward. And you can see that in this. So the top one, what I did is this is in a group of 700 patients. This is the one that had the greatest whole eye motion, so I could demonstrate it with you. So and you can see the temporal progression here on the periphery. So the blue is undeformed, the red is maximum corneal deflection, and the white is maximum whole eye motion. And you have to overlap them, as you can see in this bottom one, to actually come up with these pure corneal parameters. And I think I already told you this, these are the ones that are associated with stiffness. Now, I didn't describe stiffness parameter, but I did tell you these two deal with shape. So the stiffness parameters is load over displacement. And there's two that you can look at. You can look at, for both of them, the load is at applanation, since that's where IOP is measured. But you can look at displacement from undeformed to applanation, which is stiffness parameter at first applanation, and you can look at from applanation to highest concavity. So that's SPHC, and I'll show you in a minute. SPA1 is a cornea parameter, and SPHC tells us something about the sclera. And we have been able to look at scleral stiffness in a number of different populations and found some pretty intriguing things. BIOP is based on finite element modeling. And then this is how we calculate the load. And when you interpret them, both stiffness parameters, a higher value indicates a stiffer response. But if you look at these shape parameters, they're just the shape. So the larger value means it's less resistant to deformation. So it needs to be smaller to be stiffer. So with stiffness parameters, higher is stiffer. With these shape parameters, lower is stiffer. Is the sclera involved? Well, we looked at paired human donor corneas, one as a whole globe, one mounted as a, this is the whole globe on the far left, and then the artificial anterior chamber we used is on the far right. This has that's a contact lens, soft contact lens in it, not a cornea, but that's the same anterior chamber we used. And then we varied pressure from 10 to 50. And what we found, the first row here is the whole globe mount. The second row is the artificial anterior chamber of the fellow eye. And you can see and the first column is 10 millimeters, and then 20, 30, 40, and 50. You can see the greatest difference is at 10 millimeters. So this artificial anterior chamber, this very stiff boundary, limits corneal deformation independent of the pressure inside. There's much less deformation with a stiffer boundary around it. However, as you increase pressure at 50 millimeters, the sclera is acting very similar to this rigid artificial anterior chamber because of the properties that I told you about. And the difference between them gets lower with higher pressure. So greater IOP produces a stiffer corneal response, and a stiffer globe, a stiffer sclera, would produce a stiffer corneal response. We went on to look at this with a finite element model as well as ex vivo. We stiffened the sclera and measured an eye without a stiff sclera and then an eye with a stiff sclera, the same eye before and after, and compared them. And then we did the strip testing at the end. So this shows that this is the treated sclera, this is the stiffer sclera, and the blue one is the untreated sclera. So there's significant stiffening. And what we found, if you look at this Mancova, is that the scleral modulus is this middle column, and the ones that are significant are outlined in red, and you can see their highest concavity parameters. So when deformation is maximum, that's where the sclera becomes involved. And DA ratio, which is the shape of that, which is maximum at first applanation, not at highest concavity, it's not different. And the SPA1 is not different, but SPHC is different. So SPA1 is related to corneal response, SPHC is related to scleral response. Now, this concavity is influenced by scleral stiffness for both ORA and Corvus ST because they both deform the cornea to concavity. Now, here's my evidence. So these are patients treated in Italy where one eye had a scleral buckle for a retinal detachment, the other eye was untreated, and they measured ocular response analyzer in both eyes. And what they found, and in fact, they came to me at a meeting and because they didn't understand their results, because they didn't touch the cornea, they just stiffened the sclera with this buckle, but that reduced hysteresis. And in fact, hysteresis, there's less ability to dissipate energy with this very stiff sclera. The cornea hasn't changed. So in this case, it shows you that hysteresis reflects ocular response, not just cornea. And in fact, the point that the load is applied is at the cornea, but the entire eye responds. And what I propose is that in glaucoma, where they found that low hysteresis is associated with glaucomatous progression, and people can't figure out how something in the cornea predicts something that's happening in the back of the eye, the connection is the sclera. The sclera participates in this response. Now, what we did, this wasn't in the paper, but what we did later is we actually calculated the waveform parameters on these subjects, these same subjects. And we found 11 that were significantly different between eyes. Which ones were they? The only parameters different involved P2 or peak 2. None that were pure peak 1 or P1, none of those were different. IOPCC, CRF, and CH were different. Those involve P2 in terms of the calculation. But peak 2 was also significantly different with a greater aspect ratio, which is height over width. So the height is greater, the width is narrower, and this path around it is greater. The uprise and the downslope are greater. There's lower P2 area inside of that peak, and the width is smaller. All of this tell you that the cornea is moving more rapidly in the unloading phase, driven by this stiffer sclera. So there is a much faster recovery when you have this very stiff sclera. Glaucoma. This actually just came out very recently. I think it was November was the EPUB ahead of print. And this was a longitudinal study of glaucoma suspects. And they found that higher SPA1, this corneal parameter, with a thinner cornea, so stiffer and thinner, showed accelerated nerve fiber layer thinning. And the higher, the stiffer A1, the higher SPA1 of the cornea was also associated with greater risk of visual field progression. Now, they didn't have SPHC, so there's no scleral parameter in here, but they've clearly shown that there are stiffer eyes with thinner CCT exist. And this is another reason why you should never correct IOP with central corneal thickness. Now, the other thing I want to share with you, 7 o'clock. So this is being published in Journal of Glaucoma this year. I think there's something online posted right now, but it's not the final version. But we evaluated the biomechanical response to prostaglandins. And we looked at intraocular pressure and anterior chamber volume, as well as core-vis parameters and ORA parameters. And prostaglandins, as you all know, at least in the United States, is a first-line treatment for glaucoma. The mechanism of action involves upregulation of tissue enzymes and degradation of extracellular matrix to increase uvascular outflow. That's how it works. So it's going to degrade extracellular matrix of the ciliary muscle and the sclera. So if you change the structure of the sclera, you're going to change the properties. You're going to reduce the stiffness of the sclera. So does this change in scleral structure alter the biomechanical properties of the sclera? I kind of just answered that. The answer is yes. Do the same changes occur in the cornea? And we know they do because of this study out of China, where they showed the control group is this white dot here. They've got them kind of labeled backwards, but you have to look at the symbol. So this white group is the control group. And when they treat it with prostaglandins, it shifts the curve. So that means fundamentally they are less stiff. And then you also decrease pressure, which brings it down further on this. So the question then is part of the IOP lowering effect of prostaglandins just due to measurement error? And we looked at 33 eyes of 21 prostaglandin naive subjects. We looked at baseline 1 month and 4 months after prostaglandin. We measured our anterior chamber volume with Penacam. We used the core-vis ST for corneal and scleral stiffness, as well as central corneal thickness. We looked at viscoelastic parameters from the ORA, and then we measured pressure with 3 different devices. And we found, of course, a significant decrease in IOP with initiation of prostaglandins in all 3 tonometers. That's not surprising. But the greatest change occurred in the first 4 weeks. There was no change in IOP between 1 month and 4 months after prostaglandin initiation. Everything occurs sometime in that first month. And a significant reduction in scleral stiffness. And we use DCT IOP as a covariate because remember what I told you, IOP will confound your results. So we used IOP as a covariate, and even taking into account the drop in IOP, there was a stiffer scleral response. We also looked at the pressure volume ratios, and we did that because of Friedenwald. And I'll tell you more about that in a minute. So we looked at IOP over anterior chamber volume at visit 1, predicted the reduction in scleral stiffness for both DCT and IOPCC, not GAT. It also, this ratio predicted the IOP reduction for Goldman and IOPCC, but not DCT. And a lower pressure volume ratio leads to greater IOP reduction. So in other words, the stiffer the, oh, I'm sorry, that's wrong. Renato, this is why you can't show this. It's greater pressure volume ratio leads to greater IOP reduction. So the stiffer eye has greater IOP reduction than the less stiff eye. So the unexpected result, we know from Friedenwald that a decrease in volume leads to a decrease in pressure. And in fact, that's why all prostaglandin treatments are designed to decrease volume, because decreasing volume will decrease pressure. But we had 12 eyes that had a significant increase in anterior chamber volume and yet had a decrease in pressure. I struggled with this for days, and I checked. I thought maybe the anterior chamber volume is bad. We measured in triplicate. I went through all of them. It wasn't bad. These 12 eyes had an increase in anterior chamber volume with a decrease in IOP. So I went back to Friedenwald and I looked here. So here we have volume and intraocular pressure. So if you have this curve here, so if you increase volume, you increase pressure. You decrease volume, you decrease pressure. Well, if you have a reduction in scleral stiffness, you can go down to a different curve, and you can have an increase in volume with a decrease in pressure. And I think that's what explains here, because we have a decrease in scleral stiffness. So think about it. If you have a decrease in scleral stiffness, it's going to be less resistant to expansion, and it's going to expand. So you're going to get this larger volume even as pressure's going down. But 21 of them had a decrease in anterior chamber volume with a decrease in IOP. So prostaglandins clearly generate a decrease in ocular rigidity. When you compare the two groups, is there anything different about the two groups? There's no difference in pressure by any method. There's no difference in IOP over ACV by any method. There's no difference in anterior chamber volume. There's no difference in age. There is a difference in central corneal thickness and corneal hysteresis. So the eyes that had an increase in anterior chamber volume with a decrease in IOP started out more compliant. They're thinner and they have lower hysteresis. Those are the ones that had an increase in anterior chamber volume. The other thing, if you think about it, can you reverse, because everyone uses a 6-week washout period when they're studying drugs. And if you're looking at a drug that interferes with the pathway to produce aqueous humor, and you take that drug away, that pathway is going to start again, and you're going to get an increase in volume right away. But if your mechanism of action is to change the structure of the sclera to increase uveoscleral outflow, that's not going to turn off right away if you remove the medication. And in fact, I can tell you from evidence in the literature, there's one paper that looked at properties, and I'll show you that in a minute. 6 weeks is not long enough for a washout, for a structural change. And I don't know what an appropriate period of time is to wash out prostaglandins. So this paper is the only one that's out. What they reported is that they reported that there was a significant increase in hysteresis and IOP. And that's the first thing that caught my attention, because as we know, you increase IOP, hysteresis is decreased. So this is the first thing that said something's weird here. But they also had a significant increase in central corneal thickness. And that, I believe, is what drove the increase in Goldman tonometry. They did not report IOP-CC, but we can deduce there was no difference, because they reported corrected IOP, which is IOP-CC minus Goldman. And you can see there's about a 2 millimeter change in that parameter, and there's about a 2 millimeter change in Goldman. So that means there's no change in IOP-CC, and they didn't actually report it. I think that this increase in Goldman might have been driven by the central corneal thickness and increase, but there's no change in IOP-CC, and I would propose that there was no change in the true pressure inside of these eyes with 6 weeks of washout. So corneal deformation with ocular response analyzer and Corvis ST is influenced by scleral properties and thus ocular rigidity. Hysteresis represents ocular response rather than solely corneal response. Cornea is where you apply the load, but the whole eye responds. Prostaglandins decrease ocular rigidity, which may also contribute to the risk of reducing progression and let me explain what I mean by that. If you reduce the stiffness of the sclera, maybe that change in and of itself, independent of the change in IOP, maybe reduction of scleral stiffness reduces the risk for glaucomatous progression. Maybe that's because the sclera is connected to the lamina. And so maybe that change in the properties also changes something about the relationship between the sclera and the lamina, because it's a difference in the properties between them that can actually drive the response at the lamina. And PGAs may produce non-reversible changes in structure of the sclera and IOP measurement error with Goldman. And the other thing is, the stiffer the eye is to start with, the greater response to prostaglandins. So our next generation will be biomechanically screening. We'll look at the influence of disease development, progression, and response to treatment, and biomechanical prediction of response to intervention. And I think that is all. Thank you. So I guess I'll take questions now.
Thank you, Cynthia. It was really, really nice. I learned a lot. I have few questions in my mind here, and one of them is blinking here, which is related to what is the role of axial length on this process?
Axial length influences ocular rigidity. So in fact, we have a paper that we're just about ready to submit, where I think we can calculate pulsatile ocular blood volume, not flow, but volume, from axial length, ocular pulse amplitude, and IOP. So, you know, axial length is part of what determines ocular rigidity. So you can think of it as implicit in the ocular rigidity curve.
So a longer eye will have lower ocular rigidity.
Yes. And that's in multiple papers. That's in the literature, that a longer eye has lower ocular rigidity.
Fantastic. So exploring the biomechanical impact of the drugs on the sclera is only with prostaglandin, or do you see... because of the mechanism of action. The mechanism of prostaglandins is to change the structure of the sclera. That's the mechanism. I mean, it increases uveoscleral outflow by changing the structure of the sclera. It increases permeability of the sclera. So to do that, it changes the structure, and changing of the structure changes the stiffness. You can't, stiffness, response, and structure are intimately tied together. It's the same in the cornea, looking at Keith Meek's work and the impact that had on corneal response. So if you change the structure of the sclera, you will change the stiffness of the sclera. Thank you. So I welcome my friend Gustavo, who is now at home in very good company, and also Marcela. Please unmute your microphones and welcome to bring questions to our guest, Dr. Roberts.
Marcela, you can go first. Ladies first.
Oh, it's okay. You have a lady with you, so you can go first.
Yeah, my little lady here.
Sure. You want me to go first? Okay.
Yeah, sure.
Cynthia, thank you for the fantastic talk, and it's so good to hear from you. It seems that we never stop learning, and time flies so fast when you're speaking. It's really good. I have a few questions for you. The first thing is that I was very interested on what you showed, demonstrating the impact of refractive surgery on corneal biomechanical properties and stress distribution. And I saw you compared LASIK and SMILE patients on the simulation. My question is, did you get a chance to try PRK on this analysis, and what would you expect to find comparing these patients?
We didn't do PRK on that specific analysis. However, there are other literature studies that have compared PRK to SMILE to LASIK, and they find that PRK actually produces a stronger cornea at the end. And you know, people don't understand that, but the issue is the tension in the cap. So with the LASIK flap, there's no tension, it's gone. With the SMILE cap, the tension is reduced. It's not the same as pre-op. So if you have an increase in IOP, it's going to be carried in the bed. And the cap is going to be, I mean, if you think about it, there's some tension, but it's not the same as it was pre-op. So you would have to, before you engage the cap area, you're going to have to put a great deal of stress into the bed first.
Okay.
You'll never engage the LASIK flap area because there's no tension with LASIK.
Right. And as you said, the Corvi's ST measurements are influenced by scleral properties, right? And ocular rigidity does. So would you consider the Corvi's ST as a good device to measure IOP in post-op refractive surgery patients?
Yes. The Corvi's, the biomechanically corrected IOP, you can use post-op with refractive surgery. If you have the ocular response analyzer, you can use IOPCC. Both of them do much better post-op. Goldman's it's completely invalid. I don't want to say they do better than Goldman because Goldman does nothing. But both IOPCC and biomechanically corrected IOP are very appropriate post refractive surgery.
Okay. And my final question is, since, you know, CBI and TBI performed really well in, you know, separating normal and keratoconus patients, I was just wondering while you were speaking, if do you think they would like, with artificial intelligence and machine learning algorithms, help us to these two parameters to separate normal patients and glaucoma suspects, or even normal tensional glaucoma patients?
I think that the answer, I think that's under study. I don't think we have, you mean, so you want to separate glaucoma and but if they've had refractive surgery, if a subject's had refractive surgery and they're coming into a glaucoma practice, I think you're going to have a hard time because their corneas have been altered. So, you know, you shouldn't use applanation tonometry to measure IOP, and any kind of biomechanical algorithm that will separate, say, like let's say we find, we don't know yet, but let's say we find newly diagnosed glaucoma has a stiffer sclera than normal. If their cornea has been altered, if the point of application of the load has been altered, we don't know if that relationship would be maintained. So if someone has had refractive surgery, you need to treat them carefully if they're coming in for evaluation of glaucoma.
Right. And in untouched patients, like patients that never had any treatment, do you think these variables could help us to separate these patients, glaucoma and normal tensional glaucoma?
We're looking at that right now. I can't answer it because I don't have the answer, but we're looking at it.
Okay. All right. Thank you.
You're welcome.
Okay, my turn. Hi, Cynthia. Good night. That was a wonderful lecture. You made a kind of very hard to understand subject very more understandable for us, because you know, we're not engineers and we don't think like bioengineer people, and it's good to get some information that can we actually use in our daily practice. So it was a very good lecture in that sense, and thank you for your time. And let me ask a few questions. Actually, it's not a question. Do you have any thoughts about, you said that the curvature is related to the stress of the cornea, right? And do you have any thoughts about intrastromal corneal rings and keratoconus progression, since it decreases the corneal curvature in most of the times? And do you have any thoughts about that?
Intrastromal rings, the way they halt progression is by changing the stress distribution immediately. You know,
Mhm.
you add the rings and the stress distribution is immediately changed. And in fact, somebody came up to me years ago and said, why is it when I put intracorneal rings in that it gets thicker in the center? Why does the cornea get thicker with rings? And it's because you change that biomechanical environment, and because of the viscoelastic properties, it may reverse that cycle. So that cycle was thinning, increase in curvature, thinning, increase in curvature, with a change in stress in between all of them. Well, now you've changed the stress in the opposite direction. So you redistribute the stress immediately, and you add this artificial limbus in there with the rings. So you've completely changed the biomechanical environment. And even if you don't stiffen it, you've still changed the stress distribution.
Okay. Yeah, that's what I tell, because when we talk about keratoconus progression, and if we are asked what's the treatment to stop progression, yeah, the treatment, the answer would be cross-linking, right? But in the daily practice, we get to see some stabilization of keratoconus when we do corneal rings. So that's I think it's a good.
I have a different, little cycle there that shows how it reverses it if you put rings in. And if you combine rings and cross-linking, I know people have tried that, you're hitting two different things, because the cross-linking changes the properties and the rings change the stress distribution. So you're hitting two different mechanisms at the same time.
That's nice. And you were talking about a lot of intraocular pressure and the relationship with the cornea. And do you have any thoughts about the intraocular pressure and keratoconus progression?
Well, there's, it's an interesting, so I know in the literature, it's not keratoconus, it's ectasia. They had a post-refractive ectasia and they dropped the pressure and dropped the ectasia. The cornea will respond to the load. So if you change the load, you change the response. So if you change the load either way, you change the response. In terms of, do you want to lower pressure in keratoconus? I have no idea. You're talking there about, remember, I'm the engineer, I'm not the clinician. So I don't know what other consequences there would be for doing that. And you have to make sure you get a good measurement of keratoconus, like with IOPCC or biomechanically corrected IOP. Don't use gold bond. And it's a soft cornea, so it's probably not central corneal thickness that's causing the measurement error, but probably the lack of stiffness, the low stiffness, which is causing the measurement error for applanation tonometry.
Okay, good. And the last one, do you have the Corvis or good predictors in a set of group of normal tension glaucoma patients? Because perhaps it's not really normal tension, right? If you correct for the biomechanics of the cornea and the sclera.
I have a small set of normal tension glaucoma. I think Ricardo Vinci Guerra has published work on a larger data set of normal tension glaucoma and showed that they are more compliant even if you take into account IOP. So I don't think they're not normal tension glaucoma. But the thing I tell you, if you look at the literature, and I've reviewed a number of papers where people include normal tension and high tension glaucoma as one group. And I think it's a mistake to assume that high pressure glaucoma and normal pressure glaucoma have the same mechanism of action and will behave the same way under anything. So I think it's always important to separate those. So I think there must be something else contributing to the disease in normal tension glaucoma, since they don't have high pressure.
Okay, great. I think that's it. Congratulations for your talk. Thank you very much.
You lost your helper.
Yeah, she went to bed.
Okay.
Well, great. Cynthia, we have a question from my friend Francisco Bandeira here from Rio de Janeiro, and he's asking about finite element models to predict biomechanical changes. How these tools are useful for clinical practice. I would believe that if you just have these models without a biomechanical measurement, what's your thought about that?
That's a complicated question. you have to, models, I can just tell you from an engineering perspective, models will behave based on the assumptions you make when you build them. So if the assumptions you make when you build them are not accurate, they will not predict accurate corneal behavior. So validation is key. And the ones that I've looked out there, like there's one out there that assumes that the Corvis and the ORA have the same pressure profile. They don't. There's one that looks at Corvis and doesn't take into account whole eye motion, so they're going to overpredict corneal response. So when you get these things out of them, there's just so, and we've got new work right now which I shared with you, Renato, and it's on the end of this talk. I didn't include it because it's not quite published yet, but the load changes as a function of the shape of the deformation. So if you have a greater deform, it traps some of the air and adds to the load on the cornea. And no model is taking that into account. So you have to be careful with models. The ones that I showed based upon real people, that were comparing smile and flex. We know what the starting point and the end point is. So that one I have a lot of confidence in because it predicts the endpoint that we know. Could we a priori predict that endpoint based only on pre-op? I think that would be difficult, especially with the criteria you would have to do to get it correct. I mean, if you think about the variations from person to person, the lamellae, 3 to 500. Well, is somebody with 400 lamellae going to respond differently than somebody with 300 lamellae? And, so it's hard to look at the details enough to predict the outcome. What I think you can use it for, and I know BJ dupes, and I have no interest in this at all, no financial interest in this at all. What I know you can do is look at risk with models, because you can look at the risk of the procedure and the risk of the cornea. And that's something I know that BJ Dupes at the Cleveland Clinic has developed a model to do, as opposed to predicting the exact outcome. That's where you have to be a little bit careful. Does that answer his question? Does he have a more specific question? Is he using a model in a particular way?
Hi, Cynthia. Sorry, I cannot open my video right now. I'm not particularly presentable. I'm in the middle of a renovation. My question is regarding the work that some Italians have been doing on keratoconic eyes by implanting smile lenticules and sometimes reshaping them. Is something I began to work back in Singapore with Jod. And it's fairly unpredictable as of now. But I do know there are some people back in Switzerland working on some finite models that I didn't have access to. But for me, your answer actually is quite good, because it's kind of another realm for us. As Gustavo said before, we're not engineers and we're not programmers as well. So this kind of knowledge is out of our league. So that's why I wanted to back up my opinion.
Yeah, and so the thing of it is, if you talk, of course, Renato's going to put this on YouTube, so I have to be a little bit careful. Some engineers, I'll just say that, some engineers may not understand the clinical situation well. And so they make assumptions, and they make assumptions for mathematical tractability. And sometimes the details, even if it's not mathematically tractable, are important for determining outcomes. So you have to be, even though it looks fancy, you have to be a little bit careful interpreting them. For example, and this I can say unequivocally, there are models in the literature that demonstrate that the viscoelasticity of the cornea is not relevant on a 30 millisecond timescale. I completely disagree with that. Completely disagree with that. And if you look at the way they're designed, and some of them that claim this, their model of the cornea doesn't allow a viscoelastic response. So they assume the cornea is not viscoelastic, and then they show their model, then they build their model, and then they conclude the cornea is not viscoelastic, where that is a function of their initial assumptions. So, you have to be careful with the assumptions that are made in building the models.
Perfect, Cynthia. Thank you so much. Once again, it's very nice to see you.
For keratoconus, though, I do want to make a comment because it's pretty difficult to do any kind of study on keratoconus, for example, to determine the right nomogram for rings, where you put them.
Exactly.
But because you can't, because no two keratoconics are alike, so how can you get an experimental group or two groups that you can compare when you have no idea how to predict the responses? To me, this cries for a biomechanical model, because you can build a cornea that's a keratoconic cornea, and you can try all kinds of different things with that same cornea and see the impact that it's going to have. But I think the problem is keratoconus is not a big enough population that it's cost effective for companies to do that. But I think determining what's the right nomogram in keratoconus, it's easy to improve vision in keratoconus. So there's all kinds of different approaches, and they all improve vision because you're starting out with somebody with poor vision. But is it the optimal approach? That's the question. And the only way to determine the optimal approach, I think, is build a keratoconic model, because your criteria are not as strict as with refractive surgery. What are you trying to do with keratoconus? Stop progression, remove some of the asymmetry so you can correct with glasses or contacts. I mean, look at your goals. What is your goal with refractive surgery? Perfect vision. So the criteria are very different in those two populations. And I think with keratoconus, it would be, there'd be a lot you could learn from finite element modeling.
Beautiful. I think when you say keratoconus is hard to predict because they have a very heterogeneous behavior, I think is probably because some of these cases have more environmental ectasia and others a more biomechanically weak cornea to start with.
In a focal area, except the advanced, in a focal area. But the other thing, Hanato, if you look at the response to cross-linking between keratoconus and post-LASIK ectasia, in this case, keratoconus is far more predictable than post-LASIK ectasia. And why is that? It's because the structure is different. You look at keratoconus, yes, there's a disruption in the lamellar architecture in that one area. It doesn't have a flap. It doesn't have, it hasn't had tissue removed. It doesn't have all these lamellar segments that lack tension. So it's very predictable, despite the fact that the surface shape looks the same. The structure of keratoconus and post-LASIK ectasia are totally different, and you would expect a totally different response.
Great. We have a question from Professor Ana Luisa Hoffling-Lima from São Paulo. She's asking about the intraocular pressure measurements with the eye care tonometer, the rebound tonometer in keratoconus and post-refractive surgery patients. Do you have any experience about that?
I don't. And I think I'm going to have to try and look at it a little more deeply. We have a new chair here at Ohio State who is a big fan of the eye care. So I think I'm going to need to look at it. But the only, we're just submitting an article because we looked at droplet formation with the Corviz, the ocular response analyzer, the eye care, and the tonal pen using high-speed photography. And we're just now finishing up, getting ready to submit. And so what I can tell you at the temporal resolution of the high-speed camera, we found no droplet formation with the eye care, the tonal pen. I mean, I had to have them there as control. And the only way we found droplet formation with the ORA and the Corviz, very different air puffs, was if we added drops. If we didn't add any drops, there was no droplet formation. And it's because the tears, I mean, I know this isn't what you asked, but because I have no experience with the eye care, so I have to go into something else that deals with the eye care. What happens is when the air puff hits the cornea, Renato, I don't know if you remember years ago when I showed that two-dimensional image of the grid projected on the cornea during an air puff. And one of the questions I had with that was if the air puff would blow away the tears, and it didn't. There was enough there that it fluoresced and we had the grid, but you could see a wave of tears moving away from the center. You could see the wave on the edge. And so what happens is the tear, it's like almost touching your finger in water. The tears move away from the center. And when they hit a barrier like a lid or something like that, that's where they come out. But they don't launch. They don't launch unless you have a large tear load. So I don't know if anybody was worried about aerosolization with COVID and air puff tonometry, but it's not an issue unless you add tears.
Yeah, we have a lot of questions about air puff and COVID in the beginning, and we debated about the relevance about that, and I agree exactly what just mentioned. Excellent point, really excellent point.
But Ana Luisa, I will look at the eye care and hopefully I'll be able to answer that question next time because I just have no experience with it.
Yes, because congratulations, Cynthia. But our problem at the university is that we don't have the corvis or the aura, and we have a lot of patients with keratoconus, post-refractive and post-PK, and we need to measure the pressure. Now I'm much more worried about the measurements that we are having with the Goldman tonometer, and maybe the eye care is one of the possible solutions.
So I would guess, this is a guess, I have no evidence on normalize. It's probably okay, but what you're talking about are not normalized. I don't think it's, I think it will lose accuracy in post-refractive, I'm guessing, in keratoconus. When you measure keratoconus, about what I mean, you should have normal IOP in keratoconus. Do you get normal IOP or is it low?
Low.
It's low.
With an eye care?
No, the eye care is, in most of the cases, higher than the Goldman tonometer, even in the keratoconus patients.
Okay, so that tells you that it's, because in Goldman, you get very low readings in keratoconus because it's not so much because it's thin, I would propose, but because it's so soft. But if the eye care is higher than Goldman in keratoconus, that can give you some confidence that it's going to be better than Goldman.
And in keratoconus and post-refractive, usually it comes higher measurements with the eye care.
See, the problem with post-refractive, that Goldman is going to give you some high, some low. I mean, the reason I showed you that study is because that there were 8,000. We did our own and we compared right and left eyes, but we only had 16 subjects. But what we found is, like, even with 16, we had the same range that they did with 8,000. So with 16, if one eye went up by 5, the other eye went up by 4.5. If one eye went down by 9.5, the other eye went down by 10. So they varied together. So that tells you that there's a systematic response. It's just completely unpredictable because I think it's a function of the pachymetry profile. Now it may be with the eye care because it's one thing in the middle. The Goldman's got a larger probe. So I think that may be why this pachymetry profile interferes with it. But with the eye care, it doesn't have a large probe. So it may be better than Goldman, but I don't know how well it would do just because I haven't studied it. But it sounds like I would not use Goldman. So if those are the only two choices you have, then I would go with the eye care.
Thank you. Thank you very much.
Yes, excellent. Well, Cynthia, thank you very much. It's always very, very nice to listen to you. I always learn, and I think we all were really fortunate to listen to your great talk. Excellent, a huge overview. It was not a course. It was like a course on biomechanics in about 1 hour. So congratulations. Thank you for being available to collaborate with us. And you want to make any final comment, any final remark? I start with Marcela, Gustavo, and then you can close.
No, I'm good. I just want to thank Cynthia one more time for the great lectures and the answers. Thanks, Renato, for inviting Cynthia and everything that came tonight. And that's it. That was perfect.
Marcela, please.
Same with me. Just wanna say thank you, and hope we can meet very soon and safely. Thank you, Cynthia.
Professor, please. So
go ahead, Renato.
I just want to also, I can have to thank my colleague and the resident, for 5th-year resident, Nelson Senna, who collaborated to organize it, and OptiView to gently give us the Zoom meeting account, so that made everything possible. And this is a part of our program for the Cornea-RIO. It's a group of cornea specialists here in Rio de Janeiro that we collaborate to make science in cornea and to stimulate research and development. So thank you all, the group, and Gustavo is our main leader. Cynthia, your
Thank you.
final words.
Hopefully we'll get control of this pandemic soon and we can all meet again.
Sure.
Yes.
I hope so.
Great. So thank you very much again. Have a good evening. Be safe. Boa noite a todos. Fiquem bem, fiquem com Deus. E até breve, se Deus quiser. Cynthia, all the bless.
Thank you very much.
Family,
Appreciate
good
it.
to see you. Kisses.
Bye.
Bye.
Bye.